Hello, everyone. This is Dr. Madhusudan Rao and the program I teach medical students. The topic of today's lesson is pulmonary edema. Pulmonary edema is defined as the accumulation of excessive amount of extravascular fluid in the lung parenchyma. The fluid accumulated in the lung parenchyma in the extravascular compartment is going to interfere with the gaseous exchange, some degree of ventilatory failure, and oxygenation. That results in the systemic hypoxemia and associated symptomatology. Okay, because the tissues in the organ system requires oxygen for the metabolic activity. In the absence of adequate oxygen secondary to the impaired ventilation and poor gaseous exchange due to the accumulation of the fluid in the extravascular compartment, it results in the anaerobic oxidation and metabolic acidosis. This in turn interferes with the functionality of the various organ systems, thereby resulting in a high degree of morbidity and mortality. The causes of pulmonary edema is etiologically two types. That means pulmonary edema is etiologically divided into two categories. That is cardiogenic pulmonary edema and non-cardiogenic pulmonary edema. Cardiogenic pulmonary edema results secondary to the failure of clearing the pulmonary blood, okay, due to the left heart failure. There is increasing hydrostatic pressure in the capillaries of the pulmonary circulation, thereby resulting in the movement of the fluid from the capillaries into the interstitial compartment of the lung. Okay, that results in the pulmonary edema and its consequences. Whereas in non-cardiogenic edema, it is because of the systemic disorders or pulmonary diseases like trauma, infection, like pneumonia or inflammation, or it could be due to the pulmonary vasculitis, which results in the increased permeability of the vascular membrane to the, thereby resulting in the movement of the fluid into the extravascular compartment. This fluid is protein rich and associated with the raised oncotic pressure in the extravascular compartment. As a result of which, more fluid is shifted into the extravascular compartment, thereby resulting in pulmonary edema. Well, we are going to touch this topic in terms of its etiology, pathophysiology, clinical manifestations, and management. Let us see how it is now. This picture shows the presence of pulmonary edema. This shows alveolar filled with edema, and there is increased interstitial fluid in the lungs. Whereas this part of the lung shows normal alveoli and normal interstitium. This is in the state of normal health. This X-ray chest shows there is haziness in the pericardic regions on both sides. That is haziness in the central region of the thorax, thoracic cavity. It is called central edema, probably due to cardiogenic cause. Well, coming to the introduction to this, I have already talked to you a few points about pulmonary edema. Well, pulmonary edema is defined as the excessive accumulation of extravascular fluid in lung parenchyma. Well, when there is fluid is accumulated in the extravascular space, it results in the interference with the gaseous exchange between the alveoli and the intravascular compartment, thereby resulting in the systemic hypoxemia and metabolic acidosis, which progresses to respiratory failure. Etiologically, as I told you in the beginning, it is of two types, that is cardiogenic pulmonary edema and non-cardiogenic pulmonary edema. Cardiogenic pulmonary edema is due to inability to clear the blood in the pulmonary circulation, secondary to left heart failure. Non-cardiogenic edema is secondary to lung or systemic diseases that causes imbalance in between the hydrostatic and osmotic pressures across the pulmonary vascular bed and the interstitial compartment. Associated with the relatively elevated elevated hydrostatic pressure in the capillaries, thereby resulting in the movement of the fluid into the interstitial compartment. Okay. Well, non-cardiogenic edema is also due to inflammatory vasculitis. Okay. As a result of which, there is increased permeability of the vascular endothelium. Okay. Thereby resulting in the movement of the fluid into the extravascular compartment. As this particular fluid is protein rich and it induces elevated oncotic pressure in the interstitial compartment, there is further movement of the fluid from the intravascular compartment into the interstitial compartment. Okay. And patient presents with the progressively increasing dyspnea, cough, with respiratory failure. Okay. And there could be, you can appreciate the crepitations at the base of the lung. Etiology. Etiologically, it is two types, as I told you, cardiogenic and non-cardiogenic. Cardiogenic is also called volume overload pulmonary edema. It is due to sudden increase in the hydrostatic pressure in the pulmonary capillaries. Okay. Basically, what happens in the pulmonary capillaries, the fluid from the interstitial compartment moves into the capillaries. Okay. Because of the high hydrostatic pressure in the interstitial compartment makes the movement of the fluid from the interstitial compartment into the pulmonary capillaries. Okay. Whereas when there is a left heart failure, because of the backward pressure, the pressure in the pulmonary capillaries will be elevated. That is, raising hydrostatic pressure in the capillaries results in the prevention of the movement of the fluid from the interstitium into the capillaries. Okay. Besides, it results in the increased movement of the fluid from the capillaries into the interstitium. That results in the pulmonary edema. Well, retrograde transmission of pressure from the left heart failure in acute myocarditis, or acute myocardial infarction, cardiomyopathy, mitral stenosis, mitral regurgitation, aortic stenosis, aortic regurgitation, which are all associated with some degree of ventricular dysfunction. Okay, that results in the elevated pressure in the left atrium. So the elevated pressure in the pulmonary capillaries, thereby resulting in the movement of the fluid into the pulmonary interstitial compartment. This is what happens in cardiogenic pulmonary edema. In non-cardiogenic pulmonary edema is secondary to the diseases affecting the pulmonary parenchyma or disorders outside the pulmonary, that is extrapulmonary disorders. Either it could be sepsis, it could be the generalized vasculitis, okay, or a sort of condition with hypoalbuminemia, wherein there will be reduced oncotic pressure, resulting in the movement of the fluid into the extravascular compartment. In a situation with the generalized vasculitis syndrome associated with pulmonary edema, it results in the acute respiratory syndrome, acute respiratory distress syndrome, ARDS. This we commonly see in the conditions like septic shock or COVID with the respiratory failure. Okay. Well, pathophysiology, we have been already talking about it. It is basically because of disruption of balance of hydrostatic and oncotic pressures across the vascular membrane. Okay, which is the barrier between the interstitial compartment and the intravascular compartment. Okay, when this barrier is broken with the increased permeability, there may also be leak of the fluid with protein-rich fluid into the interstitial compartment. When there is raising hydrostatic pressure in the vascular compartment, that also results in the movement of the fluid into the interstitial compartment. Well, vascular endothelial injury with increased permeability to protein-rich fluid into the interstitial space and into the alveoli also results in the movement of the fluid from the vascular compartment into the extravascular compartments. In these situations, there is a raised oncotic pressure in the interstitium, which results in the movement of water from the vascular compartment into the interstitial compartment across the oncotic pressure or osmotic gradient. Well, elevated hydrostatic pressure in the pulmonary capillaries as a result of the backward pressure in the left ventricular dysfunction, which we are talking about in case of the cardiogenic edema, is responsible for pulmonary edema. So basically, you try to remember the dynamics of the fluid, that is the movement of the fluid from the intravascular compartment into the interstitial compartment, and in turn movement of the fluid from the interstitial compartment into the intravascular compartment is balanced by the degree amount of hydrostatic and oncotic pressures across the vascular membrane. Okay. Well, coming to the clinical presentation. Well, pulmonary edema, acute pulmonary edema is a clinical emergency because it suddenly interferes with the gaseous exchange and unpredicted high degree of hypoxemia, severe hypoxemia, results in the metabolic disturbance, thereby resulting in respiratory distress, which is progressively increasing, thereby causing respiratory arrest and mortality. So patient presents with sudden onset of breathlessness, which is not expected. It will be progressively increasing in severity, and patient will be panting for breath, tachypnea, in presence of hypoxia. When you auscultate the heart, lungs, there is basal raise. Okay. Whereas in cardiogenic edema, the patient will present with the features of pulmonary, pleural effusion, and you may appreciate that third heart sound with gallop, and you may appreciate some murmurs when there is a associated valvular disease in the form of mitral stenosis, mitral regurgitation, or aortic valvular diseases, and he will coughing out frothy sputum, which is blood stained. Well, when you auscultate the patient with a cardiogenic pulmonary edema, you will appreciate fine and inspiratory creps Whereas non-cardiogenic edema, the patient may present with a history of fever, cough, progressively increasing dyspnea, and there could be signs of pneumonia, or there could be signs of impending shock when the pulmonary edema is secondary to the septic shock. And patient may show the signs of acute respiratory distress syndrome with diffuse crepitations and bronchi and peripheral cyanosis. Well, when the patient presents with the features of pulmonary edema, we can provisionally suspect with the detailed clinical examination history whether it is the patient is present suffering from cardiogenic or non-cardiogenic pulmonary edema. Go for the confirmation of your original diagnosis with the laboratory evaluation. Brain natriuretic peptide will be elevated in conditions with cardiogenic pulmonary edema. And take the X-ray. And centralized edema is more commonly seen in cardiogenic pulmonary edema. And patchy radio opacities are seen in the case of non-cardiogenic edema. Pleural effusions are more commonly seen in patients with cardiogenic pulmonary edema. Go with the ECG to rule out the cardiac lesion or myocarditis or myocardial infarction. Do the echocardiography to understand the ventricular dysfunction or structural anomalies in the form of the valvular diseases or presence of cardiomyopathy, etc. Go for the serum electrolytes and other renal functional tests, blood counts to exclude infective etiology in the form of the pneumonia, and troponin to understand the presence of myocardial injury. Serum amylase and lipase will help you to understand the presence of pancreatitis. And pulmonary arterial pressure is the gold standard for diagnosing the pulmonary capillary pressure. Okay. And in turn, resulting in the elevated pulmonary arterial pressure. Lung ultrasound is carried out in the point of care workup in the form of lung ultrasound. Having diagnosed the patient with pulmonary edema, go about with the rapid institutional treatment. Its goal is to alleviate symptoms. So patients should improve from features of hypoxemia in the form of tachypnea, tachycardia, gallop, sometimes peripheral circulatory failure, etc. To treat the underlying condition, say if the patient is suffering from the pneumonia, treat the pneumonia. The patient is suffering from sepsis, which is leading on to the non-cardiogenic pulmonary edema. Treat the sepsis effectively. Okay. And in the beginning, to alleviate the breathlessness and move the fluid from the extravascular compartment, give diuretics in high doses. Most of the patients with the pulmonary edema, they improve with diuretics. But there could be occasionally a transient renal complications, but these are transient. When there is, give vasodilators in order to reduce the preload. Inotropics in order to increase the peripheral systemic vascular resistance in the individuals with hypotension. Oxygen therapy is mandatory in order to correct the hypoxemia. Antibiotics are given to treat the presence of infection. Prognosis is variable. It's very difficult to assess the prognosis because pulmonary edema is multifactorial. Okay, there are several conditions that result in the pulmonary edema, and the prognosis depends upon the response to your treatment while you're attending to the conditions responsible for pulmonary edema. It is difficult to predict the outcome of treatment, either in cardiogenic pulmonary edema or non-cardiogenic pulmonary edema. Okay. But with the advent of the diagnostic evaluation for early diagnosis of pulmonary edema and the early institution of the treatment, the mortality rates in many centers, it has come down to 25 to 30% when compared to earlier 50 to 60% of mortality rate. Complications. Complications are very common in unattended pulmonary edema. Cardiogenic pulmonary edema may end up in the respiratory failure. At the same time, acute lung injury with ARDS may end up in the cardiac arrest. Thank you very much for patient listening. We'll meet you again in the next class. Until that time, I request you, my dear students, to go through this important video and attend to the patients coming with the acute pulmonary edema, either it's a cardiogenic or non-cardiogenic type. And early diagnosis and effective management is going to improve the outcome of the patients in acute pulmonary edema. And we should have all the emergency treatment modalities available. And it is very important that institution of the early treatment in these patients with acute pulmonary edema is so important in order to avoid fatality rates. Thank you again for patient listening. We'll meet you again in the next class. Until that time, bye-bye.